Good afternoon, everyone, and welcome to TRI's September Innovation Seminar Series. We are happy to have Dr. Vincenzo and Dr. Kennon-McGill here with us today. They are former KL2 scholars that are going to talk to us about their KL2 research that they did with the program. They joined the program back in 2019, so they've been working on their work for a couple years, and they're going to share their results with us. So in a second here, I'm going to stop sharing and I'm going to turn it over to Dr. Vincenzo, who is going to present first, and allow her to share her screen and then let her take over the presentation.
I am Jennifer Vincenzo. I'm a physical therapist. I also have my master's in public health and a PhD in exercise science. I'm an associate professor in the Department of Physical Therapy and a KL2 mentored research scholar from UAMS since 2019. I had the pleasure of being the first scholar from the Northwest campus and from the College of Health Professions. Now I'm going to talk to you today about my research in falls prevention for older adults. About 1 in 3 older adults experiences at least one fall annually. And in 2019, Arkansas ranked 48 out of 50 for falls. So we weren't doing so well in that department. We were over the national average at 35%. I'm happy to say we have improved. We are at 38 out of 50 now, a little bit lower. And actually in about 2019, at the Centers on Aging in Arkansas, I helped them implement a falls prevention education program that they did across the state. So we hope somehow that impacted falls in Arkansas, but we still have a lot of work nationally. Falls among older adults are the leading cause of morbidity, mortality, and high healthcare utilization. They're the leading cause of injury death among older adults, and they cost healthcare over $50 billion in direct dollars. Not only that, mortality rates from falls continue to rise, and they're not sure why. It's not related to the increase in the aging population, yet we're still getting higher mortality rates. There are many causes of falls. It's multifactorial, and it can be related to things such as decreased vision, decreased strength, sensation, balance, issues with medication, side effects. The list goes on and on. It is very multifactorial, which is why it's hard to treat. Although it's hard to treat, many falls are still preventable if we do screenings, assessment for those who screen at positive for risk, and then targeted interventions. So a recent study showed implementing even a single intervention could decrease fall risk by up to 67% and save $442 million in direct medical cost. And those interventions vary. Again, we want to screen, assess, and intervene. So by screening, we identify patients at risk, we assess for modifiable factors, and intervene with specific evidence-based strategies. And in 2012, the CDC developed the STEADY for implementation. STEADY stands for Stopping Elderly Accidents, Deaths, and Injuries, and it's targeted at primary care physicians. There are a plethora of resources, but physical therapists also use a STEADY in community screenings based on my prior research, and also in clinical screenings and outpatient rehab, although there is a decrease in knowledge and use of the STEADY based on a survey I conducted. So this is what the STEADY algorithm looks like. It has been changed multiple times. A provider would screen an older adult at risk for falls, asking them either 3 questions. Have you fallen? Do you feel unsteady? Or are you afraid of falling? Or they can do a self-reported questionnaire. If the person is screened not at risk, although no one is never not at risk, so be careful about saying that, you provide some preventive education. And then if they're screened at risk, there's a way to assess all these modifiable risk factors, doing functional tests, medication review, home hazards, low blood pressure recommendations, vision, feet and footwear, and vitamin D. Based on what modifiable risk is noted, there are evidence-based interventions for each of those, including physical therapy, community evidence-based programs, medication revisions, and home modifications, among some of them. There are a plethora of study resources on the CDC website, and they're listed here. However, one of the issues that was a gap that I addressed was there was no falls prevention self-management plan for the older adult to know what to do after these one-time screenings or assessments. So there was a gap in that. What do you do after any healthcare provider screens you, assesses you, and provides you this information? So my KL2 was to develop a falls prevention self-management plan for older adults. Aim 1 was to identify self-management plan strategies for implementation after community falls risk screening. Aim 2, develop falls prevention self-management plan for implementation in community falls risk screenings. And Aim 3 is to pilot test that. So looking at Aim 1, I based my plan and aim off of the, sorry, I have to click here, the health belief model, which is widely used in health behavior change. So you can see here that there are multiple modifiable factors. There's individual perceptions about falls, and then actions that can be taken. So knowledge plays into it about falls and prevention, knowledge about individual risks, susceptibility and perceived severity of falls, self-efficacy, facilitators and barriers, and then cues to action or strategies for engaging in falls prevention. So I conducted a qualitative study using a phenomenologic approach and used semi-structured interviews based on the health belief model. I conducted 3 one-on-one pilot interviews that I did not include in the results to pilot test the interview guide and make any revisions necessary. I conducted 4 focus groups of 27 community dwelling older adults, 2 male-only focus groups, and 2 female-only focus groups. And that came about because my first focus group ended up being female only. It wasn't a priority. It wasn't pre-planned. My second focus group ended up being male only. And I found that there are very distinct differences in the way that the genders perceived falls, as well as strategies to prevent falls. So with my mentors and my co-investigator, we went forward to doing gender-specific focus groups. Now, among those focus groups, 37% of the participants had experienced a fall in the last year, and 26 participants had reported suffering and injury. So a little bit higher than the national average. We used a thematic analysis to analyze this. And I completed this right before COVID hit. I had completed all of my interviews. So then we had COVID challenges, of course, right? So all of us had our challenges. Mine specifically were having 2 school-age children at home, virtual schooling, also flipping all my classroom that I was teaching at the time online, and then trying to figure out how to conduct research when I couldn't do in-person research. But it still worked out. We did learn a lot through these Aim 1 focus groups, and my research took a couple of different turns, but in a good way. So we learned about the older adults' perceptions regarding the role of physical therapists in falls prevention in these focus groups. That wasn't originally in my plan, but I periodically meet with the CDC team that works on the study, and they suggested I include some questions regarding this because they were finding some older adults weren't perceiving that physical therapy was for prevention. So I did include that in there. I'm trying to clear my little drawing here. Sorry, y'all. I don't use those things very much. The next publication were gender differences in older adults' perception of falls and falls prevention. And my co-investigator led that, Susan Patton from University of Arkansas. And then I currently have the study that was the main focus of AIM-1 under review. Older adults, facilitators, barriers, and cues to action to engage in falls prevention. And another one, getting ready to submit regarding their perceptions and recommendations of that falls prevention self-management plan. So I'm going to talk about each of these studies. The older adults' perceptions regarding the role of physical therapists in falls prevention. No research has been conducted of that. And what we found were 4 main themes. Older adults generally had awareness of falls prevention. They were interested in learning how to fall and being able to get up from the floor. They had limited knowledge regarding the role of physical therapists for falls prevention, and there were barriers to seeking treatment from a PT. So for their awareness, if we look at these sub-themes up here, some of them don't think about it at all. They just think if you don't experience it, you don't think about a fall. Some people are more careful because as they get older, they're more careful. And a lot of people mentioned they had already taken some action to prevent falls. Most of those were around modifying their environment. Many people in different focus groups mentioned how they had a friend or they practiced getting up from the floor just in case they fall, or they were interested in learning how to fall. And then regarding their role of physical therapists, they think seeing a PT is only if you have a problem or you've already experienced a fall, not for prevention. But they did say they were amenable to, if they were in therapy, receiving falls prevention. Other themes surrounding the barriers were perceived need and cost. If they feel good, they're not going to seek out prevention. And they thought that seeing a PT required a doctor's prescription, which it doesn't. We're direct access providers, so some education lacking there. So the conclusion we have is that older adults lack awareness regarding the role of physical therapists in falls prevention. They believe they should seek treatment from a PT to address specific problems or after a fall. But the good news is that they are amenable to receiving fall prevention from a PT during an unrelated episode of care. And if there's any questions in the chat, if someone will bring it up to me, because I can't really see them. That doesn't seem like there are now. The next study we published were the gender differences that were the unexpected finding in older adults' perception of falls and falls prevention. Either the men or the women say they've seen it. They've seen it from friends, family, people they know who have fallen. The women related their role in falls prevention to helping others and being in a caregiver role, to helping a friend, to helping another family member, or even their husband. But the men are really analyzing risk and modifying behaviors. So women were talked about more being careful, using a handrail, or just use the word careful a lot. Men talked about that they maybe tripped or had fallen, and most of the time it was outside doing yard work, doing heavy labor, and how they now had to analyze their risk and modify their behaviors around that risk. So they engage in more risky behaviors. So our conclusion is that healthcare professionals should consider gender differences in falls prevention beliefs and behaviors when providing education and falls risk management recommendations. So the main study that really exemplifies AIM-1 is this one, the qualitative study of older adults, facilitators, barriers, and cues to action to engage in falls prevention using the health belief model constructs. Again, the same methods. Well, that didn't work out, right? You could see I had him coming in wrong. So if we look at the health belief model, these X's under modifying factors, we found that knowledge of individual falls risk was a barrier to engagement. A lot of people weren't aware of their individual risk. We found that knowledge of falls prevention resources was also a barrier. They weren't aware of the resources available, that they had said a lot, that their physician may have asked them if they've fallen, but nobody provided educational resources after that. Facilitator, though, was knowledge of falls prevention behaviors. As I said before, they were engaging in many behaviors already. Another barrier under individual perceptions was perceived susceptibility of falling. Most people didn't feel susceptible or weren't worried about falling. Even if they had fallen before, they didn't seem to be worried about it. They were aware of the perceived severity of what happens to other people after they suffer a fall, but they didn't take ownership that that could happen to them. They also did not seem to have the perceived ability or self-efficacy to prevent a fall or perform other behaviors outside of the ones they already perform. They did seem to believe that engaging in falls prevention is effective in reducing falls. So again, the green positives are the facilitators from the health belief model, and the red X's are the barriers from the health belief model. We did find a lot of cues to action, or what we called strategies for engagement, which we hoped would help in our development of the falls prevention self-management plan. So cues to action from family and friends was one theme that came up. A lot of people talked about how family or friends either helped them engage in falls prevention or called them to make sure they were doing okay. If they fell, came and changed their house around to make sure it was safe. So there was a lot of that, those examples. Cues to action from a doctor or pharmacist. The older adults talked about how doctors would ask them if they fell, but not always give them individualized information. And that's what they said they wanted. They didn't want general information. They wanted individualized one-on-one information. Some older adults actually mentioned a pharmacist could give them a script or something, which this is the first time I've seen that type of information come up in the literature. Usually the pharmacist only helps with medication management. So that script is what they're saying would be, how else do you prevent falls? They also talked about financial incentive or insurance companies. So one participant mentioned that they had their insurance company came out every year to do a home safety evaluation. And another person asked where that insurance company was. And the other individual actually had the same insurance, but wasn't necessarily getting that same service. So they're unsure why. People thought that the insurance company should give them incentive for engaging in falls prevention. They said that that would definitely be a facilitator. They also talked about different modes of cues to action, such as print cues to action, of course, brochures that we know about. Some people said that would help, that they could refer back to it. And some people said, we'd probably put it aside, but maybe it would help after the doctor talked to us or the healthcare provider. The gentleman talked about print like articles potentially in AARP or sports and hunting magazines. And everyone talked about having information available in doctors' offices. They also mentioned audiovisual cues to action, suggesting PSAs, news stories, and screens and videos up in doctors' offices and waiting rooms. Only a few people talked about online cues to action, which were suggested quizzes to test your knowledge about falls prevention, because a lot of people like to do those types of quizzes, and doing research on the internet for falls prevention. And only a few people mentioned reminders as cues to action. So having an alarm every day, a phone alarm, or Alexa say, have you walked today? I was surprised with a higher level of education in these older adults that they didn't recommend more use of smart devices, even though there are a lot of apps that could potentially help with this. So there are many barriers to falls prevention. We didn't find a lot of facilitators, and older adults do prefer individualized information. And there are many options for cues to action. No one really mentioned a self-management plan, ironically. So we were looking for strategies to implement in a self-management plan, and many of these are actually strategies for the broader audience. Although some people did mention a prescription for falls prevention which aligns with that self-management plan to help with engagement. So in regards to their perceptions of a self-management plan, Originally, this was going to be combined in the same manuscript, but it was just too much information and too separate because we got so much information from the strategies. But this is what the self-management plan looked like. It was taken from derived from a published self-management plan or falls prevention plan from the largest pragmatic clinical trial for falls prevention in primary care. And I added a little bit of information to cover the constructs of the health belief model. And you can see I align my interview guide with the health belief model. So on the left are the strategies. The questions we asked are in the center. And then the constructs they're aligned with are on the right. So first we had participants rank each item by level of importance before we asked them how their questions open-ended and within the group about the self-management plan. They were a little confused at first. They thought they were supposed to fill out this plan, what they thought their risk was and what they thought might happen. So I explained that it was to be filled out with them, with a healthcare provider, but they did have a little bit of confusion about that. And that was in each group. In ranking it, they had to rank it with a discrete number, 1 being the most important item that could be on the plan and 10 being the least important item. So on average, they felt the most important item was what might happen to me if I fall. And the least important they thought was how will I monitor progress? Once they started talking about the plan, most of them said all items are important. So when I started going through each of these items and asked my risk of falls is in the first column, in the second column, how does or does not this item understand my risk of falls, help you understand and acknowledge your fall risk? And they said yes, and that it needs to be in it. And they basically said that for each of them. They did not recommend revisions to any of the items. They did recommend some revisions to the plan. All but one participant liked it. They felt it would help with awareness. They did feel it needs graphics or pictures, and that possibly we should highlight more important questions in red, such as the risk of falling, so that will stand out more. So again, this was my main objective of AIM 1. It was kind of a bust. I didn't get great information to make a plan or revise one, but I did get some good other information I wasn't expecting and some preliminary data from my case 76. So regarding that plan that I derived my plan from, the results of that study came out about a year ago after I had completed this AIM. And again, they use this type of plan in primary care, but the providers only followed up once or twice after a year of conducting the fall screening and providing the recommendations and motivational interviewing. Unfortunately, they did not meet the study goal to decrease fall-related injuries, but there was a decrease in reported falls. One of the limitations was noted that they weren't able to follow up with the older adults. So we're seeing this as a huge limitation for sure. And I'm proposing to hopefully address this in a case 76 that I'm resubmitting. While I was submitting my case 76, the project is to implement falls prevention as a standard of care in outpatient rehab. So there's no literature on this, but my prior research supports that PTs do conduct falls prevention and use this study in community screenings, and some are doing it in outpatient rehab, at least via report on a survey. PTs are afforded more one-on-one time and follow-up with older adults. So if they're able to implement this while the older adult is seeing the PT, the PT would be able to conduct the follow-up that's been lacking, as well as the follow-up with the plan to support the older adult to engage in the plan. So in seeking some preliminary data for this, I found a large health system in Oregon that clinically implemented the study in rehab starting in 2017 with 24 34 clinics. So my aim has changed. So I have gone from the aim to develop a plan now to figure out how to implement the study in physical therapy as standard of care. So what I am doing is I've gotten the IRB approval. I've gotten the data use agreement. They are currently pulling the data, and I'm going to conduct a retrospective study to identify the clinical outcomes and implementation of the study in outpatient rehab. So I'm using the RE-AIM framework, which is to look at the reach, effectiveness, adoption, implementation, and maintenance. So again, my next steps are to conduct that retrospective analysis, to resubmit my K-76 to actually do this using implementation science methods, and to submit a CoStar grant. So I got a letter of intent accepted to identify barriers and facilitators to implementing falls prevention as a standard of care for older adults attending outpatient rehab. So at that rehab system in Oregon. I also conducted other research under the K, if anyone's interested, but I'm going to move on so Stephanie can talk. And I'd like to thank the Translational Research Institute, the KL2 program staff, directors, and colleagues, Center for Implementation Research, my mentors, Jeff Curran, Pearl McElfist, Jeannie Way, Leanne LaFleur, my department chair, faculty, and staff, my research assistants, the Northwest Campus, and I'm sure I forgot somebody else. So thank you, everybody. Does anyone have any questions?
I had a really quick question. I think the gender stuff that you found was really interesting, and it's kind of like, well, of course they would see, they would perceive falls differently. But how are you following up on that finding in your planned / future work?
At this time, I don't have specifics to follow up, but I think when we're doing patient-specific implementation strategies to support falls prevention, that work will come up and we'll be able to implement that a bit more, especially with the follow-up and the individualized plans.
So, Jennifer, you were mentioning all the different sort of risk factors for falls, and it sounds like some of them are really about the person and their environment, but some of it might be medication as well. I'm wondering if certain medications like sleeping pills or pain medication that put people at higher risk, might there be some way to make this more to kind of make this part of the warning that they get when they're prescribed these medications? Like, because I'm just wondering if there's some inroad that might be easier than sort of universal implementation.
Yeah, you're saying more patient education on the front end, right? So they can make those decisions. I think that's a great idea. To my knowledge, it has not been implemented. It's always coming from the physician or potentially the pharmacist, but we mostly see it with the physician in the review. A lot of the Beers criteria basically are the medications that put people at risk. But also, a lot of times older adults aren't as amenable to changing their medication, right? So I know that's a barrier. But yeah, it's like, where would you put it on the bottle or in the large handout that nobody looks at that's clipped? But I agree, it definitely could be addressed on the front end.
Yeah, just thinking like if there was some way to flag the patients who might be at higher risk so that in some way they might be more invested in participating,
You mean for future research?
Well, not just research, but even just clinically, like,
Right.
I think for people to value prevention, if they realize that they're at higher risk, they might value the prevention a little bit more. They might take it a little bit more seriously.
Yeah, I agree. And I know at least in physical therapy, we can tell them they're on medications that increase their risk of falls, but with our scope of practice, we have to refer them back to the physician or the pharmacist. So that's a limitation for us implementing them. But again, we can definitely educate them. And there are handouts on the CDC's website for that as well.
Thank you so much, Jennifer. That was great. Enjoyed it. We're going to switch gears and give Stephanie Kennon-McGill the floor or the microphone. And Stephanie, I've had the pleasure of working with her over the last 2 years. Stephanie's project is prenatal cannabis and cannabinoid use, perceptions, prevalence, and fetal exposure.
So thank you all for being here today. I appreciate it. I appreciate the TRI for giving us this opportunity to talk about our research as KL2 scholars. Speaking of the KL2, I just want to say how thankful I am to have this opportunity over the past 2 years. It has allowed me to pursue a new research path that I had never pursued before. And as a result, the things that I'm going to show you today are very preliminary, very raw data. Since I just started this 2 years ago and I just started recruiting a few weeks before COVID hit. So you can imagine how that's affected the data that I've been able to collect. But hopefully you'll still find it interesting. So the main focus of my work is prenatal drug use and its effects on infant neurodevelopment of the babies who were exposed in utero. I'm specifically interested in prenatal cannabis and cannabinoid use. So cannabis or marijuana has the main psychoactive component of THC or tetrahydrocannabinol, and it has a non-psychoactive component of cannabidiol or CBD. So THC is the thing that gets you high, CBD does not. You're probably very aware that CBD is everywhere these days. It's legal. Federally, it's legal in every state. And you can walk into a Kroger and see a whole display of CBD products. You can walk into Target and see CBD makeup and bath products. So it's everywhere. And you're probably also aware that THC has been legalized in a lot of states. So this is kind of a hot topic that has not been explored that well yet. This idea of prenatal cannabis and cannabinoid use. That's what I'm focusing on for my study. So this is a map of the United States in 2012 that shows legalization status for each state for recreational use of cannabis, which is the dark green states here. So in 2012, recreational cannabis was legal in Colorado and Washington, and that was it. The lighter green shows states where it was legal for medical use. And it's just a handful of states. You can see there's a huge empty patch here in the middle of the country, in the southeast part of the country. The reason I chose 2012 to start with to show you is because, in my opinion, this is kind of the beginning of the wave of legalization. So after this year, things kind of snowballed and lots of states started pushing for bills to legalize marijuana use. That brings us to 2021. And this is a very different looking map. So this year, there are at least 15 states where marijuana is legal for recreational use, and even more states where it is legal for medical use. This map has actually changed since I made it a few months ago. I believe Alabama, it's now legal, and maybe one or two other states. So I predict that it won't take that long before pretty much all of this map is going to be green. As you're probably aware, Arkansas legalized medical use of marijuana just a few years ago. So it's made it kind of a good state to study this sort of thing in. We're in kind of a booming and burgeoning marijuana economy in our state. And it's been interesting to study this. So even though legalization has become more widespread, does that really mean that prevalence of cannabis use has actually increased? Or is it just that it's not as taboo anymore? Well, it has increased over the years. So this figure I pulled from the National Survey on Drug Use and Health, which is a survey that is administered nationally every year to hundreds of thousands of people. And this just asks people about their use of various kinds of drugs, illicit or non-illicit, in the prior year to taking the survey. So down here at the bottom, we've got just some major classes of illicit drugs. We've got opioids, cocaine, meth, heroin, and hallucinogens. And you can see those are all down here. This is from 2013 to 2019. And this is the percentage of respondents who endorsed using these drugs at some point in the prior year. And something to point out here is that these drugs, the use of these drugs has not really increased over time. In fact, if you look at opioids, this yellow line, it seems to have decreased since, at least according to the survey, since 2015. But if you look at this green line up here, this is marijuana use. This has increased every single year from 2013 to 2019. And I'm just kind of assuming that the 2020 results are probably even higher. So not only is the marijuana use, much higher in prevalence compared to these other drugs, but it's also increasing every single year. So I'm interested in, this is just a general population. I'm interested in prevalence during pregnancy. And this has been looked at in at least a couple of populations. So this is a study that was published in 2019 where they surveyed women in the Kaiser Permanente health system. So they looked at over 300,000 pregnant women who gave a self-report for marijuana use during pregnancy. And this is the adjusted prevalence of cannabis use percentage of the women who responded. And they asked if they used it at any time at all during pregnancy, which is this gray bar here on the top, or monthly or weekly or daily. And as you can see here, there's a very similar trend compared to the general population where we're seeing an increase in use from 2009 to 2017. So the women who endorsed using marijuana at any point during pregnancy nearly doubled over this time period. And again, I haven't seen updated data. This ended in 2017. I'm assuming it's going to be even higher in the last few years. So I was interested in looking at the prevalence among women in Arkansas. So this is, these show general population in the US, pregnant women, these are pregnant women in California. But what about women in Arkansas? So we're in a state that, has recently legalized medical use. What is it like here? So I created a survey and implemented it with one of the MPH students here at UAMS through the use of the AR Research Registry as well as social media. So we created this survey, distributed it. We had a great response. We had over 800 respondents, which was fantastic. And of those 800 respondents, I was really interested for the purpose of this part of the study in female residents of Arkansas who were between the ages of 18 and 60, because that covers the reproductive window. So we had 480 women who fit into this age range who answered the survey. And we asked them, have you personally used marijuana or another form of THC in the past year? Just have you used it at all? Surprisingly, over 30% of these women endorsed using marijuana in the prior year. This was surprising to me because it's much higher than the national average. So I just wasn't expecting to see a number that high. I'm not going to get into this too much just for the sake of time, but this is just broken down, the demographics broken down by age, education, race, ethnicity, and residential area. A couple of things just to point out about our sample. It's skewed toward women who are 45 and older, and also skewed toward higher educated women who had graduate or professional degrees. So in the future, I'd like to possibly implement another survey and reach a broader population in Arkansas. And we also asked this question about prevalence of CBD use. So we asked the same question, have you personally used CBD products in the past year? And again, over 30% of the women endorsed yes for this question. Actually, 35% of the women said that they had used CBD in the past year. So that was just for all of the women, whether or not they were pregnant in this survey. I was then interested in figuring out which of these women were pregnant and what the prevalency was among the pregnant women. We know based on the study that I showed you earlier that there are pregnant women who use marijuana, there's not really any good data on pregnant women who use CBD during pregnancy. But I wanted to show you these pictures. I just pulled them from Google. Just a quick Google search. These are pictures that are targeting pregnant women to use CBD. So CBD is advertised as something that is kind of a cure for what ails pregnant women: pain, anxiety, insomnia, nausea. So there are targeted advertising campaigns that advertise CBD for pregnant women. So although we don't actually know the prevalence of CBD use in pregnant women across the country, it's not a leap to assume that there are pregnant women using CBD. So we ended up having only 12 women in our survey population who were pregnant at the time of taking the survey. And there were 40 women who were planning to conceive while taking the survey. So hopefully, if they're planning to conceive, they're going to get pregnant soon. And of these women, of the pregnant women who took the survey, almost half of them endorsed using THC sometime in the prior year, which doesn't necessarily mean they were using it while pregnant. They might have been using it in the months leading up to pregnancy. And about a quarter of them endorsed using CBD. And then again, in this population of women who are planning to conceive, the percentage of women using THC was lower, but CBD was still about a quarter of the women who are planning to conceive endorsed using CBD. So that covers a little bit about the prevalence of THC and CBD during pregnancy. And because this is an issue that seems to be increasing in prevalence, there are more and more women using these things during pregnancy. I think it's also really important to understand the other thing that really caught my interest was the perceptions and perspectives of these women who are using these drugs during pregnancy, as well as the perceptions and perspectives of their providers. So if there are more women using these drugs during pregnancy, then this is an issue that's going to come up more and more in the clinic. So I was interested in looking a little bit about just perceptions in general of safety of using THC or CBD during pregnancy. And there have been a couple of studies, qualitative studies, that have looked at this sort of thing. This first one, I thought it was really interesting. They interviewed obstetric providers about their attitudes and counseling strategies regarding their patients who use marijuana during pregnancy. And they found that the providers did not view marijuana as harmful as some other substances that may be used during pregnancy, but they also didn't, they said that they reported that they didn't really have a good understanding of the medical consequences of prenatal marijuana use, and that these two things together caused them to deprioritize the topic during the obstetric visits. And that when they did counsel their patients, they really just focused on the possibility of legal consequences or involvement of Child Protective Services, which is not helpful to these women who are going to be using marijuana during pregnancy anyway. And then on the flip side, there's a qualitative study where they interviewed pregnant women who use marijuana during pregnancy, and they found that while these women had contradictory beliefs where they wanted to kind of reduce their usage, they continued to use, and they felt that marijuana was more natural or was a safer alternative to other substances that they may be prescribed during pregnancy, such as Zofran for nausea or something like that. And this is just anecdotally, I found this to be very true with the population of women I have in my study who use THC during pregnancy. They feel that this is a safer alternative for their babies. But we don't actually know. We don't really know, which I'll get to in a second. We don't really know how this is affecting their babies. So we've got, on the one hand, women who believe this is safe. And then on the other hand, we have clinicians who don't actually know what to tell their patients. So this is a really important topic to study, in my opinion, so that we can help these women and help these babies who are being exposed in utero. So we did ask our survey participants, we asked them to rate whether or not they agreed or disagreed with these statements that marijuana or another form of THC can be safely used while pregnant, that's on the left here, or while breastfeeding. And while a majority of people reported that they strongly disagreed with these statements that marijuana was safe while pregnant or breastfeeding, the next highest percentage of respondents were neutral on this topic. And then there were people who strongly agreed or agreed that marijuana was safe while pregnant and breastfeeding. So this is still a controversial topic. I think that perceptions are really changing along with prevalence. So it's something that needs to be studied. And I think that these survey results kind of point to that. So there has been a little bit of research that's been done previously on cannabis research, cannabis use during pregnancy and its effects on the baby. Those studies that have been done have mostly looked at neonatal outcomes as well as longitudinal neurodevelopmental outcomes. So looking at things like prevalence of ADHD in adolescents who were exposed prenatally. And there have been a couple of big hitter studies where these were cohort studies, large cohort studies of women who were pregnant in the 80s and the 90s. And these studies followed their children and up through adolescence and looked at all different kinds of neurological outcomes. I'm not expecting any of you to read this chart. I pulled it up here. This is just pulled out from a review that looked at the results or outcomes of some of these studies. And I wanted to pull this up to show you, just to illustrate a few things. So you'll see arrows popping up. So for this study in the MHPCD cohort, they found that prenatal marijuana use led to decreased body length in the babies who were born in the neonates. So this is a neonatal outcome. However, in this other study, they found no effect on birth weight, length, or gestational age. And again, in this other study, they found, again, no effect on birth weight, length, or gestational age. So there's some disagreement there in the outcomes from these three different studies. And again, the OPPS study found increased tremors, exaggerated startles, and diminished responsiveness to light in neonates. However, this other study found that the neonates were, or at 1 month, they were less irritable, more alert, more autonomically stable. And then at 1 year, one study found decreased motor scores, whereas the OPPS study found no effect on motor scores. So this is kind of the current state of the research that's done on this prenatal marijuana use and its effects on the babies. It's just kind of, you look one way, it says one thing, you look the other way, it says the complete opposite. And there could be a reason for this. So most of these studies are epidemiological in nature. So they rely on self-report. And which means we have really no way of knowing the exact exposure levels of the babies. So some of the studies ask moms, who were pregnant 20 years ago and say, did you use marijuana while you were pregnant? Well, first of all, it's hard to recall those sorts of things so many years ago. And it's not like they're going to be able to tell you the exact dosage that they were using. So that could lead to differences between studies. Another issue is the potency of marijuana. So the ratio of psychoactive THC content to non-psychoactive CBD content in typical cannabis products that you would buy on the street or at a dispensary has increased from 14 times to 80 times between 1995 and 2014. So if you remember, some of these major studies were done on women who were pregnant in the 80s and the 90s. So the drugs that they were using at that time were much weaker, much less potent than the drugs that moms are using now, which means that babies who are exposed now are being exposed to something that's vastly different than what babies were exposed to previously. And then the other thing is just to point out, like I said, there's extremely limited prenatal CBD research. So I'm actually not even gonna touch on that. There has been a little bit done looking at if CBD gets too the baby in the placenta, but there really hasn't been anything done that's looked at least not in humans, that has looked at how CBD is affecting neurodevelopmental research or neurodevelopment of babies. So that leads me to my KL2 study. And like I said, this is a pilot study. It's preliminary data. I'm just going to mostly talk about what I'm doing and how I'm doing it, and then I'll have a little bit of data to show you at the end. So I am interested in knowing, how does prenatal THC or CBD use affect infant neurodevelopment, specifically in the first year of life? And to do this, I'm looking at a few different factors. So I'm measuring the amount of THC and CBD and their metabolites using analytical methods, so I can get an exact picture of the quantitative exposure for these babies, which is something that is not currently done in the research. I'm also looking at longitudinal neurodevelopment. So I'm interested in seeing how these babies develop over their first year of life. And then I'm also interested in a mechanistic portion of this neurodevelopment. So DNA methylation, alterations in DNA methylation have been implicated in other aspects of marijuana use and marijuana exposure, not necessarily in this specific population of prenatal use. But I'm interested in seeing if the DNA methylation profiles of these infants is different from infants who were not exposed. So to do this, I'm aiming to recruit 60 mother-infant dyads, so 20 moms who are using THC regularly, 20 who are using CBD regularly, and 20 controls. And I'm going to talk a little bit, and this goes over the period from third trimester up to the first year of life of the baby. I'm going to talk a little bit about the actual study design here. So this is the two main components of the study. And the first one is exposure, and trying to figure out exactly how much these babies are being exposed to when their mothers use THC or CBD. So to do this, we do the initial consenting and intake, and during this time, I administer a detailed drug use survey. I ask moms about all of the drugs and supplements that they're using during pregnancy, and then also get a maternal blood draw. And then if they're using CBD, I ask them for a sample of their CBD products so that we can potentially measure exactly how much CBD they are being exposed to. And then when the mother comes in to give birth, we also get the umbilical cord blood, as well as 24-hour venous blood from the babies. All babies who are born at UAMS get their blood drawn at 24 hours, so we just get a little bit of extra blood from that. And then we take those samples and we do liquid chromatography, tandem mass spectrometry to quantitatively measure the amount of THC and its metabolites, as well as CBD in those blood samples. And then the other main component of the study is the neurodevelopmental and mechanistic portion. So at 6 and 12 months, we ask the moms to bring their babies in. We administer another drug use survey to account for if the mother is breastfeeding, to see if the baby's been exposed postpartum. And then we administer 2 neurodevelopmental assessments. One is the Ages and Stages questionnaire, and the other is the Bayley scales of infant and toddler development. These allow for analysis of different neurobehavioral aspects, motor development, cognitive development, speech development, that sort of thing. And then at this time, we also get a sample from the baby to use for DNA methylation. And then I also plan on doing DNA methylation measurements on the cord blood samples as well. So I wish I had more to show you. I do have a data slide after this, but I just wanted to talk to you a little bit about my current research progress. I have recruited 28 mother-infant dyads, 17 in the THC group, 1 CBD, and 10 control. That it's been very interesting to me that I cannot find CBD moms. I can only find 1 mom so far who uses just CBD and not THC as well. So I'm not sure. This is kind of a continual issue for me. I'm not sure if they're not out there. Maybe this population who uses CBD is less likely to risk it during pregnancy, or maybe they don't want to be associated with a study where we're also looking at THC because it's more taboo. I have no idea. So I'm trying to find these moms. But so far, recruitment isn't that bad. I've got
I'm sorry to interrupt, but we're almost out of time.
Okay.
So I wanted to just maybe you can, if you have 30 seconds to wrap up, maybe we can have.
Let me get to this is my data slide, just real quick. So we just have some preliminary data, very raw data of our exposure measurements. And so what you're looking at here, the first 7 are blood samples from control moms. And this is, we're measuring THC and its metabolites and CBD. And you can see we found nothing in the control moms. That's great. There wasn't supposed to be anything there. The one CBD mother, 33, we found CBD in her blood. And then the last 3 are THC moms. And we found, we did find detectable levels of a THC metabolite in the maternal and umbilical cord blood of these moms. Just want to note that we didn't find it in the babies at 24 hours after birth. So that's something that we're going to investigate further. And yeah, so basically in the future, I want to do this on a larger level with neuroimaging involved and look a little bit more into prevalence.
Yeah, so Dr. Kennon-McGill, thank you so much for that interesting presentation. I think the landscape has changed so much with marijuana over the last several years. It's really interesting to look at some of the unintended consequences. And Dr. Vincenzo, also wanted to make sure to thank you for your presentation. We're almost at the top of the hour, so I'll open it up to one question, but I did just want everyone to know, thank you for coming to Innovations. I know some people have to sign off right at the mark of the hour, but we're excited to see our KL2 scholars doing such interesting work. I'm really proud of them, and it's exciting to see the discoveries they are finding. So any questions for Dr. Kennon-McGill? Well, I have a question for you. So the advertisements a lot of times that are geared towards pregnant women, it seems like that's a lot of times geared towards like nausea and morning sickness and some of the things in maybe early pregnancy. Like, do you have a sense of when during pregnancy people might be using THC?
So that's a good question. Some of the moms I've talked to, they were using it in the beginning and then they tried to stop as time goes on. So I think a lot of them are using it mostly in the first trimester if they're not using it throughout pregnancy. And you're right, because they also have issues like nausea and insomnia, things like that are more prevalent in the first trimester. To be a part of my study, they have to be using it the entire time. So I don't have as much data on that though.
And do you know if most of the women who use it during pregnancy had been using it prior to pregnancy, or
Yes.
is it something that they just started?
No, most of them were, or perhaps all of them were regular users, and a lot of them have their medical cards as well.
Thank you all. And it was another great evening of talk. So if you have any problems getting your CE credit, I guess talk to Nia, but I think she put the information up there. So hopefully you'll be able to get your CE units. Okay. Have a good evening. Thank you.